All right, let's dive right in. Today, we are breaking down a topic that is absolutely essential if you're going into pediatrics or neonatal care: respiratory distress syndrome. If you've ever wanted to truly understand what's going on inside the lungs of our tiniest patients, you are in exactly the right place. But before we get into the nitty-gritty, here's a question for you. What is that invisible, absolutely crucial substance a newborn needs to take its very first breath? The answer to that question? Well, it's the key to this entire condition, and we're about to uncover it together. So let's start at the very beginning. We're going to look at the absolute core of the problem, a tiny, newborn's desperate fight for every single breath. So what exactly is respiratory distress syndrome, or RDS? You might also hear it called hyaline membrane disease. That just refers to these glassy-looking membranes that can form in the lungs. But at its heart, it's a breathing problem in premature newborns, and it's all because they lack a substance called surfactant. Without enough of it, those tiny little air sacs in the lungs, the alveoli, they just collapse, making it incredibly hard to breathe. Okay, and I really want to pause here for a second, because this isn't just some abstract theory. This is a high-yield, absolutely must-know subject for your board exams. So everything we're about to cover, it's designed to help you crush those questions and, way more importantly, to be an amazing clinician. This slide just shows the magic of surfactant so clearly. Look at the left. With surfactant, the alveoli pop open and stay open, the lungs are flexible and squishy, and breathing is basically effortless. Now look at the right. Without it, the lungs get stiff, and those little alveoli collapse on themselves. That's a condition called atelectasis. It's like trying to blow up a million tiny, sticky, wet balloons with every breath. The difference is just night and day. Okay, so we know what the problem is, but why does it even happen? In this next section, we're going to see how this whole condition unfolds like a chain reaction, set off by a few really key factors. And here they are. You know, you might want to get your highlighter out for this one because these are classic multiple choice questions. The number one risk, the big one, is prematurity. See, surfactant production really ramps up in the last weeks of pregnancy, so any baby born before 34 weeks is at a super high risk. Another huge factor is being an infant of a diabetic mother, because the high insulin levels in the baby can actually stop surfactant from being made. C-sections without labor and birth asphyxia are also major risks you'll see. And right here, you can see that domino effect in action. It all starts with not enough surfactant. That leads to the alveoli collapsing. With those air sacs closed for business, oxygen exchange just plummets. This causes hypoxia, low oxygen, and hypercapnia, that's high carbon dioxide. The body's chemistry gets all out of whack, it becomes acidic, and if we don't stop it, it leads straight to respiratory failure. It is a rapid downward spiral. Okay, so you know the cause and you know the cascade. Now, how do you actually spot it as a clinician? This next part is all about putting on your detective hat and reading the signs, the clues that tell you a baby is in serious distress. Time is everything here, so knowing the difference between early and late signs is absolutely key. Early on, the baby's body is trying its best to compensate. You'll see tachypnea, that's really fast breathing, along with nasal flaring and this audible grunting sound with every breath. But if things get worse, you start to see the late, really dangerous signs like apnea, which are actual pauses in breathing, and bradycardia, a slow heart rate. Our goal is always to intervene before we ever get to those late signs. And to confirm what you're seeing, you'll turn to these definitive tests. The chest x-ray is the classic. You're looking for a ground glass appearance. It literally looks like a hazy, frosted pattern all over the lungs. That's a hallmark of RDS. Then, an arterial blood gas, or ABG, will show exactly what you'd expect: low oxygen, high CO2, and an acidic state. And of course, the pulse oximeter will show that oxygen saturation is dangerously low. We've found the problem. We've confirmed it. Now for the most important part. What do we do about it? This is the action plan. This is how we support these tiny fighters through the crisis. So, medical management has a few key cornerstones. We provide oxygen support, anything from a simple hood to a ventilator, along with IV fluids and antibiotics. But the real game changer, the MVP of the treatment plan, is surfactant replacement therapy. We can actually give artificial surfactant directly into the lungs to replace what's missing. It is a true lifesaver. Now, while the medical plan is critical, it's the minute-to-minute, hands-on care at the bedside that makes all the difference. For you, the future nurse, this is your playbook. This is where you shine. Priority number one, always and forever, is airway and breathing. You're going to position the baby in what's called a semi-Fowler's position to make breathing just a little bit easier. You'll suction gently as needed to keep that airway clear, and your eyes will be glued to the monitor, constantly tracking respiratory rate and oxygen saturation. Now, with oxygenation, it's not just about giving oxygen. It's about giving the perfect amount. It's a delicate balancing act. Your goal is to keep that SpO2, the oxygen saturation, right between 90 and 95%. This means you're watching those ABG results like a hawk and working closely with respiratory therapy to manage the ventilator settings. Now, you might be thinking, temperature? I thought we were talking about lungs? Well, they are completely connected. A cold baby burns up precious energy and oxygen just trying to stay warm. Oxygen they desperately need for their lungs. That's why we use a radiant warmer to prevent what we call cold stress. Same goes for nutrition. We use IV fluids at first because the baby is working way too hard to breathe to even think about feeding. And finally, it's about seeing the whole picture. You're monitoring everything. Vitals, daily weights, how much urine they're making, their blood sugar. But just as important as all those numbers is supporting the family. You're not just treating a set of lungs. You are caring for a tiny human and their terrified parents. Your calm reassurance, your clear explanations, that is a critical part of the care plan. So, we've managed the crisis. The baby is starting to stabilize. For our final section, let's look ahead. What are the potential long-term risks? And most importantly, how can we prevent RDS from ever happening in the first place? The stakes are incredibly high. Without really effective management, RDS can lead to some serious long-term problems, including chronic lung disease, collapsed lungs, severe infections, even bleeding in the brain. This list really just drives home why early and aggressive treatment is so vital. But here is the really hopeful part. We have some powerful tools for prevention. The most important one is giving antenatal corticosteroids, something like betamethasone, to a mother who is at risk of delivering preterm. This medicine actually crosses the placenta and helps the baby's lungs mature faster and start producing their own surfactant. It is a brilliant and highly effective strategy. And that brings us to the end. We've uncovered that invisible substance, surfactant. We've seen the dangerous chain reaction it can cause when it's missing. We've learned the signs to look for and the life-saving actions to take. So I'll leave you with this thought. Knowing all of this, knowing the risks, the signs, and the response, how can you help turn the tide for our smallest, most vulnerable patients?